roaring in the morning sun, searching for a longer day. People feeling like the light has just come. We must never stop the way, yeah. Birds chirping and I hear my name, grasping into a life. Life is happy but it's so insane. We must merely make a start. Savannah, I'm coming home. Savannah, we'll never be alone. Savannah.
Of Shriram Chandra Bhanja Medical College and Hospital. Please welcome with a huge round of applause. Dr. Dinabandhu Sahu, Team Leader, National Health. Dr. Padita Pawan Mahanti is the patron of AOPSACON 24. He is the Director of SC Netcar Old Court. Please welcome. Like every
समस्त मान्यगण्य व्यक्तित्व माने आपण समस्त सामने प्रति प्रज्वलन पूर्वक श्री जगन्नाथ आशीष विद्यालय आज जगह कार्यकारी
Good morning, students. I will call my students because I am teaching physiotherapy or BPD students since final year, and we are staying in one hostel, second hostel in MKC Medical College. Dr. Dinabandhu Sahu sir and आप लोग का जो द्रोणाचार्य I will tell he is the द्रोणाचार्य of your college, and all of you students, Dr. Padita Pawan Mahanti sir and all the students. So and he was being cured by your professor Padita Pawan Mahanti. So मोर भी साल बहुत भक्ति अच्छी तेणु आम तो पढ़े चलु वी आर टीचर्स बट द एक्चुअल टीचिंग इज बाय योर इंस्टीट्यूट. तो सब पे कहे पे सब यू ट्राई टू नेटवर्क जाओ से भल आसो एंड समटाइम्स ऑल्सो आई गॉट सम नेगेटिव फीडबैक. मोस्ट ऑफ द स्टूडेंट्स आई नो कौटी किए कम कर कन्फेस कर पचारे से पिला कौटी कम कर कम कर सब तुम मैंने पेसेंट सेवा कर चल कर्तव्य कर चल सब तुम जे मुझे फाइनेंशियली साउंड नहीं हेवी सब यू डू योर ड्यूटी प्रॉपर्ली तामने पेसेंट जब गोटे बेनिफिट है तुम मान द्वारा तेणु सी आउ 10 जन को कह से भल थेरापी कला आम भल ही आसलु तेणु आम खाली मेडिकल ट्रिटमेंट दौचु.
नमस्कार Dr. Akash Kumar Behera, Dr. Malika on the diet, the office bearer of all ODISHA Service Association, the invited guests, the physiotherapists, participants, the students. Good morning to all of you. On behalf of all Odisha Physiotherapy Service Association, I welcome all of you for this conference. I am really amazed to see the whole hall is filled up. I was not expecting such a big crowd, so I must thank the office bearer for arranging for this such a conference. Regarding physiotherapy, as already the previous speaker have already told you, physiotherapy has been recognized as a branch of modern medical science. So physiotherapy, every individual requires physiotherapy, starting from mother's womb till death. Every individual requires physiotherapy. Even normal individual also requires some kind of physiotherapy for their fitness, for improving their efficiency and quality of life. Then the importance of physiotherapy, that is in prevention part, and coming to the treatment part, where physiotherapy can independently diagnose and independently treat the patient, that is, in orthopedic medical condition. In orthopedic medical condition, about 85 to 90% problems are mechanical in nature, which can be treated by physiotherapy alone. So what is required is every physiotherapist should be good in clinical evaluation. The strength of physiotherapy. So how we are different from other medical professionals is clinical evaluation, and through clinical evaluation we can establish the diagnosis, and it is said that literature said that the clinical diagnosis is more valid, more reliable than radiological diagnosis. So what I want to say, every physiotherapist should be very good in clinical evaluation. Once you do the evaluation, treatment is not a very good thing. Our therapeutic treatment is no more limited to the equipment. In orthopedic medicine, almost mechanical problem can only be treated by manual therapy. So again, one has to develop the manual skill to treat the mechanical dysfunction, mechanical derangement of the body. Physiotherapy is the only healthcare professional, those who know the biomechanics of the body. So by the knowledge of your background knowledge of anatomy or biomechanics and evaluation skill, you can prove your efficiency. And once, as I told, government has taken all the measures to recruit physiotherapists, starting from CSC level to PSC level. And time has come, physiotherapists have to show their efficiency, have to return back to the society. People cannot come to the left, right? We get about 500 patients daily in different parts of the state, not only from the state of ODISHA, from neighboring states and from even outside the country also. You'll be happy to know NETAR has signed a MOU with Manchester Metropolitan University. Their students are coming and taking internship program, undergoing internship program at NETAR. At present, one girl from South Africa has come and undergoing internship at NETAR. So what I want to say, you have to develop the district physiotherapy center in a center of excellence, so that the people from the same district at least should come to you as on first contact. Every genetic patient needs physiotherapy. You must be knowing in all Western countries, the geriatric home, physiotherapy, occupational therapy plays very important role there. So, realizing that government of India, government of Odisha, they have also taken measure to create this geriatric physiotherapy for the senior citizen physiotherapy unit at the educated level. In neurology, all patients require physiotherapy, though it is supportive, it is complementary or supplementary to the medical treatment. But this is very, very important. After the patient gets discharged from the hospital, physiotherapy is very, very important to make the patient fit and return back to functional activity. Early return to functional activity. In sports, everyone knows what is the importance of the physiotherapy. Then physiotherapy is the most important component in sports field. Starting from, in obstetrics also, physiotherapy plays an important role for early and easy childbirth. To prevent, I hope this conference is going to be a grand success. Thank you. Thank you.
ଯେମିତି ଆପଣମାନଙ୍କୁ କହୁଥିଲି ଏ ମଞ୍ଚ ଗୋଟେ ଲିଗେସି ବହନ କରେ ପୂଜ୍ୟ ପୂଜାର ଏବଂ ଆମ ସହିତ ଉପସ୍ଥିତ ନ୍ୟାସନାଲ ହେଲ୍ଥ ମିଶନ ଓଡ଼ିଶା ମହୋଦୟ
an honor to have you here, sir. Now I'd like to request Dr. Padita Pavan Mohanty to felicitate Dr. Akash Kumar Behera, actually Neurology Department, Sri Ramchandra Bhatt Medical College and Hospital. We need to have a louder round of applause, please. Audience.
Definitely all of you being felicited by the director to really
तो भाई आम आगे को डिस्कशन जारी रखा बर्तमान आम जानवा को चाहिए जे आप जो समस्यार सम्मुखीन हेले तापर आपणकर मानसिक स्थिति कौन थी शारीरिक स्थिति तो आम समस्त जानी मानसिक स्थिति कौन थी आपमि बाहर जो गोटे
सबको नमस्कार 2014 मोर स्पाइनल इंजरी होता स्पाइनल इंजरी पर 19 दिन पर मुझे नेक्टार पहुँचली सर्जरी पर से मो मन में केवल गोटे क्वेश्चन था मुझे चलि 3 मास पर मुझे सेम क्वेश्चन करी आ 3 मास पर्यंत पूरा जी जान लगे फिजियोथेरापी कली आ 3 मास पर पुणी सेम क्वेश्चन देते गली तो सर मैंने कहले आम चेष्टा कर देखिए कौन हम तो से फिजियोथेरापी करने बंद करदेली एमती कि फिजियोथेरापी टाइम रे जो असेसमेंट हुए असेसमेंट रे भी सहयोग कलेनी तब निजे निजे कौन करुच्ची कौन न करुच्ची एते डिप्रेशन में चली चलिए न चलिए यार भितर तबरे जने सार थिले हमर से कहले कमल जदि तमे न चली परबा और बहुत किछि भी करि परिबो तापरे मुगली बहुत किछि करिकी किछि फायदा भी नहीं तापरे फिजियोथेरापी बंद कर देली पूरा गोटे वर्ष तबे सेही ओलटपुर रे घर नै के रहउतली किंतु फिजियोथेरापी करिया को आसी नथली ओके वर्षक परे गोटे फंक्शन को मते फर्स्ट चित्त सर कहले तू से फंक्शन आस की देख जड़े पिल्ला आते हमर बिहार रु जी को व्हीलचेयर चले कि एका एका हम नेता को आसते तापर मु से प्रोग्राम देखला पर सर मते पचारले मैडम सर मते पचारले तू चाली की जदी भी चाली बोलू चाली की कोन करिबो तो मु चाली की ये करबी से करबी पुणी खेलीबी एमती सब कहली तापर चित्त सर मते ये पिला जेती करछि तो सेती करिया को चेष्टा कर सेबेठु मोर जर्नी स्टार्ट हला तापरटू मु केबे जानिनी जे मु कोन करबी मो पई मु भाबी जे मोर गोटे लाइफ सेडू सरगला सेकंड लाइफ नेक्टर आरंभ होला आ मोर जो गाइड अछंती हमर पीपी सर प्रति स्टेज रे मते या करिबो आगु को या करिबो मते लागो छी मोर शेष पर्यंत जेत पर्यंत मु बंचीबी तार प्लानिंग सर मो पे बने की रखी छंती बेली मु पूरा मजबूत विश्वास से बने की रखी तेणु मते या फिर किसी भाबिया नहीं सर जहा कहउछंती मु सेया करूची आ मते स्पोर्ट्स रे कोन मिलिछि न मिलिछि सेडा त कोन जानि जंती किंतु हेल्थ रे मो एति जानि परछि जे कभी कभी मु लुचि के एमती होछि एक्सीडेंट जे भले गेला शायद लाइफ एते खुशी आगु माने निजदी नॉर्मल था कि हेइ न था
Many patients, they come to the neurology OPD with low backache, sciatica pain, lumbar claudication, that is known as neurogenic claudication, acute PIVD. Before going to neurosurgery department, they usually come to us. Usually, every patient don't want to go to surgery department for surgical decompression or something. So many patients have low back after a fall. Young boys girls after sports injury, and many patients having acute lifting heavy weight after cycling, bicycling or motor driving, they come to us with low back pain. So usually those patients are computer professionals or they are having bad postures during reading, and to restrict some activities like forward bending, weightlifting, prolonged cycling, exertion, and usually more than 40 to 50% they are being cured, but they will have to adapt some procedure. Usually young people recover very fast. Then if now investigation procedures are available, if you do the MRI of young boys and girls also, they MRI people are giving the report there is some disc prolapse, mild to moderate disc prolapse. But they are coming with the MRI only, and sir, is there any need for surgery? So that is not the need for surgery. We have to collectively decide the patient's symptoms, then the signs, then the radiological findings. Then we can decide whether the patient will be decompressed in the orthopedics or neurosurgery department. Then we refer the patient to the neurosurgery department. If they will decide that surgery is required, and sometimes they also advise surgery, and sometimes they require advice to do conservative treatment and do physiotherapy and take adequate rest for some times. But it is not known how much time it will take for recovery. Or regularly, if there will be physiotherapy, I have experience. If they will go regular physiotherapy for 1 to 2 months, 15 days. Also, they are being greatly relieved, symptoms and signs are relieved, and they are able to do their day-to-day activities, and they can manage their day-to-day activities and daily life. So, usually all the back pains are presenting early, and treatment gets early, and rest adequately, they are being cured. And some people are, some of the patient comes with a acute low back pain, then he went doing the day-to-day activities, doing manual labor. So these patients usually develop disc prolapse, and they develop neurological symptoms, very severe pain. So that patients will require surgery, I think, after doing some adequate investigation, and usually refer the patient for neurosurgery for opinion regularly, or orthopedician for regular, or spine surgeons. But that is my opinion. So usually clinical examination is the utmost important. Patient comes, you do the clinical examination. If there is no neurological deficit, MRI finding some disc prolapse, mild disc prolapse, you advise them some medicines, advise them to take adequate rest, and then re-examine the patient after 1 week or 2 weeks. If the patient, you advise the patient, if you see any neurological problem, you are having any difficulty in walking, you are having any bladder incontinence of bladder bowel, you are having any sensory symptoms like numbness in the perianal area, so always you suspect some Kodai-Kuhn syndrome, then you advise immediately for imaging, and surgery may be required at that time.
Thank you, sir. Dr. P.P. Panti, sir, he has a huge experience in treating the low back pain and other musculoskeletal conditions. So, sir, I want to ask a question that when physiotherapy is exclusively indicated in the low back pain condition?
Low back pain, we divide low back pain into only 2 types. One is specific and other is non-specific. Specific means where there is a specific diagnosis can be given, like spondylosis, PIVD, or spondylitis, or maybe tubercular spondylitis, or spondylolisthesis, like that. Those specific diagnosis is given. And the other category is non-specific, where no specific diagnosis can be given. About 85% low back pain are non-specific, where there is no pathological diagnosis can be given. And those non-specific low back pain are considered as mechanical low back pain. And when the problem is mechanical, see, your body is like a machine. So, any machine, you find there is something wrong in a machine, whatever, you send to the mechanics, right? So, I consider physiotherapists are mechanics of the human body. They know the biomechanics, they know the movement science, so they can find out where exactly the fault. Whether the fault is in the muscle, there is muscle weakness, muscle tightness, there is any soft tissue problem, there is problem in the maybe the disc problem or joint problem. So specific physical diagnosis. In physiotherapy, you use the term physical diagnosis. Diagnosis, is usually met after clinical evaluation and all other investigation diagnosis is met. But in physical diagnosis means we physically, clinically only examine the patient without any investigation. We complete. By interpreting and coding the data, physiotherapy is complete. But when when he goes to orthopedic surgeon or whoever it may be, they usually advise for the those analgesic, the muscle relaxant, etc. Some exercise. But in physiotherapy, we exactly try to find out where is the point, whether the problem is in the joint capsule or the muscle tightness or whatever. So depending on our specific clinical diagnosis, we make the intervention. If the problem, the limitation is due to muscle tightness, like supraspinal tendinitis, you have to go to the stretching exercise. And if the problem is in the joint capsule, which is seen in case of adhesive capsulated arthritis, you go for the joint mobilization technique. There are various mobilization techniques. So, what I want to say, in case of low back pain, you have to thoroughly take the history, clinical evaluation, come to the physical diagnosis, and based on that, you have various manual concept, like you have the serious concept where serious says all the back pain is due to the disc lesion. But it may not be true exactly with investigation nowadays, with various investigation, it may not be true. But serious says all the low back pain is due to this lesion, and it divides the disc lesion into two types, one is short disc lesion or hard disc lesion. Short disc lesion is nothing but your chronic intravertebral disc. So accordingly, serious, if the flexion, extension and side flexion, the affected side is limited and painful, that is known as your short disc lesion, where serious recommend for the traction. Whereas the hard disc lesion occurs in elderly person where the disc is degenerated and one develops spondylosis. In that case, we go for the various manual correction. Similarly, we have got one concept like McKenzie concept where McKenzie says divides all low back pain into three categories, like dysfunction syndrome, where the movement is limited, and derangement syndrome is nothing but your frontal disc and postural syndrome. Most of the condition cases of low back pain could be postural in nature, and he recommends restoration of the normal lordotic posture. Normal lordotic certificate. If it is exaggerated, you reduce it. If it is reduced, you have to restore it. Because normal lordotic posture is the most stable posture, where the load is distributed, the muscle activity is the minimum. So like that, you have to clinically diagnose the patient, and accordingly you have to make the you have to plan the physiotherapy treatment and execute it. And regarding the rest, when somebody suffers with low back pain, usually is advised with the rest. In case of someone prolapsed intervertebral disc, this is a avascular structure. It derives its nutrition, from the vertebral body above and below by a process of diffusion. That is only possible with the movements. If you give absolute rest, the disc is deprived of the nutrition. So, its healing is going to be affected. Maybe 2 days, and literature says, experiment says 2 days bed rest is as good as 2 months bed rest. So maybe in very active condition, 2 days bed rest and followed by some movement. In Western country, in case of PIB, they go for the mini squats, static cycling, etc. Without forward bending of the lumbar spine, because aerobic exercises are also recommended. So that what happens with aerobics, body won't pain inhibiting mechanism and endorphin and capillary secretion service facilitated. So, depending on, again I repeat, clinical diagnosis, clinical evaluation followed by diagnosis, the treatment hospital plan and therapeutic intervention has to be executed in all mechanical low back pain. And if it is a specific diagnosis, spondylosis also come under specific diagnosis. PIB needs spondylolisthesis. Again, these are also mechanical and can be treated by physiotherapy. If there is some infection, acute traumatic condition, maybe the secondary carcinoma, etc., but physiotherapy, these are the red flag for the physiotherapy. Where physiotherapy is absolutely contraindicated. So, though 1 or 2% of low back pain may be infected, carcinogenic also, but you have to be very cautious. If wrongly you start treating those patients, you are in trouble.
Thank you, sir.
Sir, we want to discuss in details about low back pain. So, yes, people do come to us regarding opinion regarding surgery. But in this construct, I will not go to all the details and everything. There is what are absolute indications for surgery. I have absolute indication only 4, not 5. Only 4 absolute indications. One is there is bladder valve involvement. That means patient is developing severe urinary incontinence. 1. Second, patient has even leg weakness. There is foot drop is happening. And 2. And third is claudication. Okay, claudication means patient cannot, previously used to walk up to 5 kilometers, now even cannot walk to the bathroom also. Claudication, severe claudication. And 4th is failed conservative treatment. Already taken 6 to 8 weeks of medications, physiotherapy, injections, all failed. After 6 to 8 weeks of conservative treatment, there is failure. Still patient having severe pain, cannot sleep at the night. These are the 4 indications I would recommend surgery. And yes, all these symptoms should be and must be clinically correlated with the MRI and X-ray findings. That's it.
People get panic and also consults neurosurgeons and other professionals.
Obviously, in pain, patient develops weakness. So we have to examine detailed clinicals. We go to the muscle power testing, we go to the jerk testing. So there we can differentiate whether it is a pain or whether there is a neurological compression. So there we can differentiate and go. And yes, I have told you, this is all clinical. So clinical, if there is a DTR is gone, and there is a SLR strictly positive, and there is a big disc herniation, not mild or small disc herniation, then we advise. For only small weakness, grade 4, we don't advise surgery.
Despite having the neurological complications and other complications like bowel bladder involvement also, a few people, they become panic to consult a neurosurgeon. They have some kind of a notion that the surgery may cause some more harm to them. So, what should be your opinion, sir, for them, sir?
See, panic, the only solution, panic is counseling. Gain their confidence, explain detail about the disease, explain about what will be the prognosis, what will be the future. If there is a small disease, patient is panic, and give them pre of physiotherapy. I advise pre of physiotherapy and also post of physiotherapy. That is a part and parcel of every neurological disorder, and to be specific, neurosurgical disorder. In my neurosurgery patient, when my physiotherapist is not there, I will not advise for surgery. That's my motto.
Thank you, sir. Thank you so much, sir.
So you see, according to the site of lesion, so paraplegia means weakness of or paralysis of both lower limbs. If the patient is having a central disc prolapse, the patient may have bilateral lesion and patient will have lower motor neuron paraplegia. So usually everybody must know that spinal cord ends at the lower border of L1. The lower border or the lower level lesion is known as conus, surrounded by epiconus. So if the conus area is involved on examination, you will find plantar will be bilateral outgoing in spite of the patient is having a lower motor neuron lesion or upper motor neuron lesion. So paraplegia or paralysis of the both lower limbs patient may have due to acute PID also, central disc prolapse, and also involvement of the conus cauda lesion in acute PID or chronic PID. So usually the PID patients develop weakness of one lower limb only, usually PID patients, and before that the patient will have some radicular pain, that is like the pain in a particular root distribution, severe lancinating pain, and the pain is increased after coughing, sneezing or change of posture. Usually unilateral pain and unilateral symptoms is very common in acute PID or chronic PID. And when the patient will have bilateral lesion, that is maybe due to central disc prolapse, and plantar will be flexor in that patients, and there will be bladder bowel involvement. There will be sensorilla starting from S1 to S2, 3, 4. May sometimes perianal lesion sensorillus is very important. Bladder bowel incontinence, bilateral foot drop is very important in that patient. But upper limb, the lower limb lesions usually having upper motor neuron type like hyperreflexia is very uncommon in paraplegia patients due to PIVD. Only sometimes we may get plantar bilateral extension due to involvement of the conus cauda lesion. So you may get paraplegia. There is nothing to worry about it in PID also.
Management of spinal cord injuries should start, in my opinion, at the spot of injury, not at the hospital. Okay, at the spot of injury, suppose any of them side by or passenger seeing there is injury, patient is not able to lift his legs or hands, please do not unnecessarily mobilize the patient. Ask the professional to come and then mobilize the patient. Or even if you are mobilizing the patient, put that there, it should be taken care. The spine, they should not move with respect to each other. They should move as a whole. So first is, do not, if you do not know clearly, please do not move the patient haphazardly. Call the professionals. This is the at the road, at the spot of the accident. In the hospital also, the immobilization of the spine is the most till perfect diagnosis or intervention is not done. Usually in context of paraplegia occurs usually in the thoracic spine, not in the lumbar spine injuries. And quadriplegia occurs in the usually cervical spine and above. So in all these cases, please do not mobilize. If you mobilize with help of professionals, and in the hospital, and try to reach the hospital at the earliest. And if there is usually in the accidental paraplegia or quadriplegic patient, usually there is this bony deformity, severe dislocation, usually not 100% cases. Most of the cases there is bony fracture and dislocation, and we have to repair it as soon as possible.
They develop other complications like other musculoskeletal complications or other complications related to vascular conditions and all. So I want to ask Dr. Mohan sir to put some beacon on the topic that how to manage or prevent the complications due to quadriplegia or paraplegia, and how to improve the quality of life of those paraplegics and quadriplegics.
In case of spinal cord injury, when I come across, I always ask whether this weakness or paralysis develops immediately after fall or after some time. Most of them will get the answer, the limb was moving as of, following injury or these things after some time. So as Sarah told, the treatment starts right from the spot. So how you transfer the patient, that is more important. And patient should be early treatment has to be there. Maybe conservative or maybe surgical. If it is an unstable one, always surgery is preferred once the spine is fixed. Only rehabilitation can be started. Now most often, the patient positioning is very important. The paralytic patient, because of gravity, the limb is externally rotated, the foot is plantar flex. If the patient develops the tightness contraction, it will be difficult to correct those. Patient may develop. People understand if you give massage, severe massage, vigorous massage by some oil or soap, the patient is going to be alright soon. I've seen patients in some hospital also the attendant apply vigorous massages. By that they develop myositis ossificans or heterotopic ossificans once patient develop, particularly the hip joint and all. So that is again very difficult to be handled later on and rehabilitate those kind of patients. That is absolutely a difficult problem. So patient attendant should be educated from the first day how to handle the patient. Because these are long-standing chronic problems. So one cannot be hospitalized for a long time, or therapies also cannot be given. Therapists cannot be engaged for a long time. So patient education, the attendant education regarding the positioning, regarding the patient should be taught every 2 hours, the skin care, the joint care, the muscle care, etc., body care, etc. has to be thoroughly taught to the patient, the caregiver, so that those complications can be prevented. You have to give passive movements, it's okay, but not vigorously. Not necessarily throughout the day or every hour you need to do passive movement. Passive movement should be slow, and experiment showed that 2 days passive relaxed passive movement twice daily is adequate enough to maintain joint range of motion, to prevent contraction, and vigorous passive movement also may give rise to injury and myositis ossificans formation. So those things very particularly massage and vigorous passive movement has to be avoided. And I have seen people giving electrical stimulation, even the physiotherapy giving electrical stimulation to those paralytic patients. There is no sensation. If you go for the electrical stimulation, patient lying in bed. So again, those things has to be avoided. When there is no sensation, those electrical stimulation, heart fermentation, etc. has to be avoided. Patient education is very, very important. Kamalakant has already told. Patient should be well motivated. Similar kind of patient, those who have come over those complications, let the patient interact with them so that they will come over and he will be motivated and he will cooperate with the rehabilitation.
Thank you, sir. Sir, I want to ask another question, sir. Sir, how the assistive technologies and assistive devices can improve the quality of life and functional abilities of the patient who have quadriplegia or paraplegia?
Yes, those in case of complete lesion or partial lesion, those who are not going to recover. Obviously, you have to make their life easy. There are certain barriers. There is social barrier, attitudinal barrier. That creates problem. Patient become withdrawn. We have seen patients, they don't like to return back to home because the kind of care they get in the hospital and in the hospital environment, they are not going to get those in the family and the society. So for years together they want to stay in Olopur. I have seen few patients. So this assistive devices like suppose somebody having paraplegia, safe home can be given, knee, ankle, foot orthosis can be given, and with the help of working at like the crutches, one can be done ambulatory. And if the lesion is too high, like 10 or above, it becomes difficult. Maybe physiological standing and walking is must to prevent various complications like contraction, osteoporosis, etc. bowel complications. So if the patient cannot walk in the community, at least he should be encouraged to walk inside, or maybe if walking is not possible, patient must stand every morning and evening, so that various complications can be prevented. And there are various assistive devices, various orthoses are available, various assistive devices are available. Usually that is evaluated and provided by occupational therapy department to perform their activities of the daily living. And various motorized wheelchair are also available. Government of India, there is active scheme assistance to persons with disability where nowadays very sophisticated aids and appliances are given free of cost. Also with 80% disability, motorized wheelchair are also given free of cost. And mechanical wheelchair, manual wheelchair, those who are available.
less than 80%, 40% to 80%, which are also getting assistive devices play a very important role to restore their ambulance, their mobility. We provide the motorized wheelchair so that one person with high level paraplegia also can go for some business, he can go for some business and all that. With assistive devices, various vocational training can be given. The ultimate aim is how one should be met. His livelihood, he should earn his livelihood independently. That is important. So it is a teamwork starting from the orthopedic surgeon, neurosurgeon, the therapist, the vocational trainer, right? And it should be really good.
Sir, when there is a lesion above the T6 level, there is a severe complications like autonomic dysreflexia. So while treating, when a physiotherapist treats a patient with injury level above the T6 level, sir, sudden autonomic dysreflexia happens. So what should be the role of the physiotherapist at that point, sir?
In that case, you have to check, usually there may be some blockades. In the catheter there could be some blockage that immediately that has to be handled. If there is, that should be corrected. And physiotherapy usually require more of medical care than the physiotherapeutic intervention. To my knowledge, because actually my experience in the spinal cord injury is not that fast. So what I know, simply you have to check in case of autonomic dysreflexia, you have to check the catheter. If there is a blockage, that need to be kink there. If there is a kink and all, that should be correct. So we require more of medical intervention than therapy.
Thank you, sir.
First is the earliest stabilization. That is the earliest stabilization is spinal cord injury, spinal cord injury and spinal bone injury. Bone injury is always the fixation. Cord injury, the latest most physiotherapists are there taking care. There is nerve stimulations, everything. From neurosurgical point of view, it is the stabilization. And a perfect alignment and stabilization of the bones is the key for future improvement.
सोल ऑफ फुट पेन किछटा भाग रही 90% पेन जाऊँगी.
We try to find out, which maneuver reproduce the origin. Suppose, as you told, in case of all sciatica patient develop spasm of the piriformis muscle. Because piriformis passes underneath the piriformis. In about 10 to 15% of the cases, sciatic nerve passes through the piriformis. Like brachial plexus passes through the skeleton group of muscle, also piriformis. So in any case of sciatica, there is spasm of the piriformis. And when you talk about the spasm, because spasm is a protective phenomenon, I always believe you treat the pain. People say you have to wait till the pain subsides to start the physiotherapy. But I always say physiotherapy is meant to relieve the pain. Even in acute condition, maybe acute PID, like the injury of the annular fiber. So like any soft tissue injury, you have to give rest. Because if you go for the only mobilization, manipulation, etc., that injury is going to further increase. Similarly, in case of any sciatica where there is a spasm of the piriformis, spasm of the hamstring, there is neural tension in positive, I always recommend never go for the stretching of the muscles. As we are talking about the gluteal pain, that is because of piriformis spasm. So as you treat the original pathology, sciatica is not a diagnosis. Any other condition can give rise to radiating pain along the course of the sciatica, that is it. So you have to diagnose what is the specific cause of the sciatica. And accordingly, intervention has to be given. With the intervention at the pain subside, the protective muscle spasm of the piriformis, your paraspinal muscle, your hamstring is going to be relieved. Then, the gluteal pain subside, the SLR is going to improve. And as you are talking about the lateral foot pain, through my experience, what I find, this lateral leg pain is due to tightness of the piriformis. Because when the muscle is spasm over time, muscle adaptive shortening occurs and piriformis tightness, that when you go for the release of the piriformis, then lateral bend subside. Still if it persists, maybe movements are pulled, lordosis is restored, joint play doesn't reproduce the symptom, but still the lateral leg bend persists, then you have to go for the neural mobilization, your sciatic nerve mobilization, you have to go for. So that helps. Then some other time, neural mobility is affected. Why the neural mobility is affected? Because there are certain tension points. When the piriformis is tight, there is spasm, there is tightness. So the neural mobility across the piriformis may be affected. Then the neural mobility of the sciatic nerve along the head of the neck of the fibula may be affected. Then the posterior tibial nerve mobility behind the lateral malleolus may be affected. So in those cases, sometimes what happens is fibular head mobilization, some other cases the lateral malleolus mobilization also help in relieving those symptoms. So again I say, clinically you find out which one is reproducing the original symptom, and accordingly the treatment has to be planned and executed.
Thank you, sir.
What they do after going to wards or sometimes to the patients, they immediately start mobilization technique. Whether they have learned from you or they are starting in voluntarily, I don't know. But sometimes, usually, as you told that piriformis syndrome, usually any patients go with back pain also. They start doing the piriformis exercise. Is it necessary or not necessary? And mobilization technique, usually you are an expert. But most of the students, they are working under you, but everybody don't know how to do the mobilization exercise. So I ask the students, advise the students, so you learn properly the mobilization techniques somewhere, not from TPSR or somewhere else. Then you start doing your practice, doing mobilization exercise. And immediately most of the students, what they do the ultrasonic and IFT. Is it necessary for any type of low back pain or not necessary? What about your experience, Amarendra? You tell. Or sir will give me some explanation.
Sir, you will know responsibility.
Sir, when there is pain, yes, people go for the ultrasound therapy. Ultrasound help in relieving the muscle spasm. I have already mentioned spasm is a protective phenomenon that protects. That protection should not be broken. That should not be our first aim. Once the original pathology subsides, that protection is going to be automatically going to vanish. So person with back pain will take medication, continue to do his activities. Then in that case, what happens? The problem, suppose I have got a mild disc lesion. With medication, when I continue to do all my activity, my traveling, my sitting, bending job, definitely my disc problem is going to aggravate. So, piriformis stretching, as I told, in all cases of sciatica, there is piriformis spasm. It's there, piriformis appears to be tight, but again, that should not be broken immediately. That is going to relieve, as you treat the original pathology, as the pain subsides, the spasm is going to subside. And regarding mobilization, mobilization is the most difficult part of the physiotherapy. It is a specialization within physiotherapy in Western countries. Even undergraduate level, students are not allowed to undertake manual therapy or do manual therapy. One must have 2 years experience following undergraduation to undergo manual therapy technique. And to undertake manual therapy, one should be again very good in evaluation. You try to find out what exactly a patient with ankylosing spondylitis could able to turn the foot by compensatory movement, stretching, hypermobility of the hamstring. But it doesn't mean that his lumbar spine flexion is normal. Usually people say, no, he is touching the foot, his lumbar flexion is normal, but that's physiotherapeutic evaluation requires very thorough, very keen inspection. I could able to extend my neck, but that neck extension might be occurring at the upper cervical level. My nose, cervical thoracic junction is absolutely ankylosed. That is possible. So more thorough evaluation, inspection and palpation is required to come to the diagnosis, and based on that only you can have the treatment planning and treatment. You can apply it. So not everyone required mobilization. There are various techniques. You have to find out to which category this patient comes, and there are various concepts. Which concept you have to use. That must have thorough knowledge. Otherwise, you will do more harm to the patient rather than doing good.
The Department of Physiotherapy, please give him a huge round of applause and welcome him on the dais, and we'll continue our panel discussion with him as well.
Thank you, Susan. To recover from a spinal cord injury, sir.
So actually, in the spinal cord injury, when a patient comes to hospitals, particularly after getting treatment, either surgery or after some conservative managements, then we saw the patients, and we have to evaluate the patient properly so that we will know that whether the patient is complete or incomplete. So if it is complete is there, our goal will be totally different and easy also, because we know the level, so what maximum patient can achieve. So then statistically we will manage accordingly. So whether patient can walk or not, or whether if patient is working, is able to walk, whether patient is required in orthosis or not. So accordingly we have to plan it. If its patient is incomplete, so chance of recovery is there. So again, in case of incomplete also there are different categories there, classification is there, by which also we have to know that how fast patient can recover. Sometimes if its quadrilateral lesion is there, if it is incomplete, only sensation, if it is only toss sensation is present, so that patient sometimes may not recover at all also. Even if sensation is there, but it will not recover. If it is pain sensation is there, the chance of recovery is more. And some patients I have seen in my lifetimes, very few patients, but they recover fully. And many patients, they recover, incomplete patients, 50% patients, they recover also. So accordingly you have to plan, and ACS skill is helpful also to find whether patient is complete or incomplete.
Thank you.
This is over. One phase will come. Patient wants that for the recovery, so you have to explain that your recovery may not possible. So you can change your lifestyles and quality of life by choosing some professions. So here actually our directors at present is here also. So he has put some interest to develop some alternative ways to treat the patient, as well as to improve their quality of life. That is the reason why our two students, they started some sports activities. So from then we found that the patient's quality of life improved tremendously. Not only that, they are very active also. So you are supposed to know that so around 50 to 100 patients, they are very active, and they can go independently. They can do their CS independently. They can stay outside. So they are very much independent. They can go by train, by flight also. So that's why they can do tremendously many work also, as well as vocations, as well as sports. Particularly in the sports scenario, we used to give some training, special training, means some strength training, flexible training, as well as for pain management, if patient is having pain management. I was also listening to sir. Neuropathic pain, sir was telling that medication drugs is there. But I saw that very chronic patients, after taking many years of drugs, so if they are not getting reduction of pain, so they are not using that. And some patients, they are using for continuous years together. So in that scenario, so whenever they are doing, they are involving in different recreational activities and sports activities, their pain level also reduces. And so for that, we are giving hydrotherapy unit is there, and some stimulation exercises is there also. Then we are also planning to do some coach-related exercises. Some coaches are coming to our institute and they are giving some training also. So initially we are different sports, now people are getting training, and once they are getting some state level medal and they are getting some state level goals, and with help of that and staying also in the Bhubaneswar, they are now practicing hard. So probably after 1 to 2 years definitely you will get some international medal also. National medal also some comes to patients got it.
Thank you, sir.
So even if 10 years before, even if my mind was also same thing, 10 or 15 years before. But once I saw the ability of the patients, so the question will come, so whether if a paraplegic patient can swim or not, if quadriplegic patient can swim or not, complete quadriplegic patient at C7 level, whether he can swimming or not. So it is possible, so they can do it. And if you see only, you can visualize. Suppose say for example, patient is sitting, so people will come and will say that you cannot do any work. So we saw a nurse, of course is a paraplegic, so she can do anything, everything there are day-to-day activities, even if with wheelchair. Similarly, example of Kamal Khan, so he can do himself, he is staying years together alone without help of their attendant. So similarly, the people, they are going outside and they are without any attendance, so they are very confident about activities. So that is the reason why. So first our goal will be to improve their function. So different functions, how much he can achieve. So there is no limit. So you will try to explore how much patient can do it. So by seeing one patient also, patient will motivate it. So that is the reason why sir told that we are also managing some program. So we are calling some few trainers. Even now Kamal Khan also. So they are also helping. Is a role model, so that people will, particularly patient will see, any initial patient will come, they see the ability of the particularly these patients, so they are also self motivated, they can also compete each others and they achieve their best goal.
एक पैराप्लेजिक पर्सन जो कि तमिलनाडु से आए थे, वो आर्मी मतलब एक्स आर्मी थे, तो उस समय पे उनका एक बात मुझे बहुत भावुक बना दिया था। तो वो अंग्रेजी में बोल रहे थे, तो मैं उसको हिंदी में या मैं उसको ओडिया में ट्रांसलेट कर रहा था। तो उस समय पे वो एक चीज़ बोले थे कि रास्ते में भी पत्थर है, पहाड़ में भी पत्थर है, लेकिन हर पत्थर का नसीब में ये लिखा नहीं होता है कि वो भगवान बने। तो हम वही पत्थर है जो तराशे जाते हैं और भगवान बन जाते हैं। तो का रोल क्या है उसमें, इसमें निर्तल का रोल क्या है, और बाकी जो आपका परिवार के सदस्य है उनका भूमिका क्या है?
थैंक यू सर। मैं यहाँ तक पहुँचने में मेरी लाइफ में जो हुआ थोड़ा लंबा हो सकता है, मैं बोलता हूँ एक एक करके। इंजरी के बाद अभी फर्स्ट जो क्वेश्चन सारे लोगों ने आंसर किया कि लो बैक पेन, वो मेरे साथ हुआ, मेरे साथ भी था। मुझे बैठने में भी तकलीफ होता था, और लो बैक पेन तो पूछो मत, मतलब सारे लोगों तो बता देते हैं लेकिन हम नहीं बता पाते हैं। मैं बताता हूँ कितने टाइप का मुझे लगता था। मेरा T4 कंप्लीट इंजरी है, मतलब चेस्ट में जहाँ नेपुल होते हैं वहाँ से नीचे तो कुछ फंक्शन नहीं है, कुछ सेंसेशन नहीं है, कुछ नहीं है, सेंसेशन नहीं है, फंक्शन नहीं है, फिर भी दुनिया भर का पेन है। सेंसेशन नहीं है, फंक्शन नहीं है, फिर भी ऐसा लगता है किसी ने हरी मिर्ची ग्राइंड करके लगा दिया है। कभी कभी ऐसा लगता है कि नीचे से कोई रोलर चढ़ा दिया, कभी कभी ऐसा लगता है कि करंट चल रहा है, कभी कभी ऐसा लगता है कि नीचे कोई कीड़ा घुस के ऊपर से नीचे तक काट के जा रहा है, भी आ रहा है। ऐसा कैसे? और ये ऐसा लगेगा कि आपको अगर यहाँ पे कभी खुजली होगा और रात भर बैठ के खुजाते रहो, फिर भी वो खुजली ठीक नहीं होने वाला। इतना सारा प्रॉब्लम्स, और यही प्रॉब्लम की वजह से रोज मेरे चीते सर के साथ झगड़ा होता था। सर आप बोले थे ठीक होने के लिए, नहीं हो रहा है। ओके, तो फिर सर ने मुझे बोले कि ये जो लो बैक पेन है ना, उसको ठीक करने के लिए तो व्हीलचेयर चलाना स्टार्ट कर। और स्पाजम था मेरे शरीर में, मतलब आज भी है स्पाजम, मैं अभी भी आपको दिखा सकता हूँ लाइव। ये वाला, इसको भी कुछ लोग देख के बोलते हैं तेरा पेट काम करता है, नहीं ये अपने आप हिलता है थोड़ा बहुत। मैं सोने के टाइम कुछ ना बहुत तेज चलता है। शुरू में ये बहुत ज्यादा था, ओके, और जिसकी वजह से मैं गिर जाता था, बैठ नहीं पाता था, कुछ नहीं कर पाता था। सर ने बोले तेरे बैक पेन और जो भी नीचे पेन हो रहा है और इस पाजन को ठीक करने के लिए तू थोड़ा थोड़ा व्हीलचेयर चला। तो मैंने पहले 100 मीटर व्हीलचेयर चलाया, तो उस दिन रात को अच्छा लगा, सो गया। लेकिन यही 10 दिन के बाद ना फिर जैसा पेन ऐसा हो गया। फिर 200 मीटर चलाया तो ठीक लगा, फिर 300 मीटर, फिर 10 दिन के बाद 300 मीटर, 10 दिन के बाद 400 मीटर। ऐसा जैसे मेडिसिन का डोज बढ़ता जाता है ना, तो मेरा जो व्हीलचेयर चला ना वो बढ़ता गया। लास्ट में पेन तो थोड़ा ठीक हुआ, लेकिन व्हीलचेयर चलाने में वर्ल्ड रिकॉर्ड बन गया। ओके, ये फिजियोथेरेपी मेरे लाइफ में दिया। दूसरा, आपने बोला ऐसा कोई राज्य नहीं है जहाँ पर नॉर्मल लोगों के साथ मैराथन, मतलब ऐसा कोई मैराथन नहीं हो रहा है इंडिया में, सिर्फ हिमालयन मैराथन और पूरी बीच मैराथन। क्योंकि बीच मैराथन बीच के साइड में होता है ना, मेरा व्हीलचेयर नहीं चलेगा। और हिमालयन मैराथन पहाड़ पे होता है, उसमें मेरा व्हीलचेयर नहीं चलेगा। ये 2 मैराथन को छोड़ के आप ऐसा कोई मैराथन का नाम नहीं बोल सकते जहाँ मैंने पार्टिसिपेट नहीं किया और टॉप 5 में नहीं आया। हमेशा टॉप 5 में आता हूँ मेरे व्हीलचेयर पे। और ये मैंने आज तक फिजियोथेरेपी और 4 लोगों की वजह से किया, नृत्य की वजह से किया। मेरा कोई नेशनल इंटरनेशनल कोच नहीं है। और इतना नहीं, मैंने जैवलिन फेंकने में मेरा यही पिछले जस्ट 2 महीने पहले गोवा में नेशनल हुआ था, मुझे सिल्वर मेडल लगा है नेशनल में मेरी कैटेगरी। और इसके साथ साथ है सर को मैंने बोला ये बैक में तुरंत पूरा पेन आ रहा है, तो पीटी सर ने मुझे बोले तू तैरता नहीं है, पानी में जाके तैरना सीखो। 2 स्टूडेंट भेज दिए, मैंने तैरना स्टार्ट किया। तो पहले डूब गया, फिर धीरे धीरे स्टार्ट किया। और आप लोग को बता दो, तैरना सीखते सीखते अभी मैं नेशनल सिलेक्शन हो गया हूँ। आज न्यूज आया है नेशनल के लिए सिलेक्शन हो गया। इसमें फिजियोथेरेपी किया, कोई कोच नहीं मिला, कोई कोचिंग नहीं। अभी सर ने मेरे लिए बोला है कि तुम्हारे लिए निर्धार में जगह कम है, तुम जाके कॉलेज स्टेडियम में रह के प्रैक्टिस करो। अभी बोले हैं सर ने। लेकिन पिछले 9 साल से मैं रिहाब के साथ जुड़ा हूँ। और रिहाब मेरे लाइफ में कुछ भी हुआ, मैं सच बताता हूँ, मुझे अगर बुखार होता है ना तो सर के पास उसका एक्सरसाइज है, नो मेडिसिन। मैंने आज तक एक बार भी यूरिन टेस्ट नहीं कराया और मुझे कभी यूरिन इन्फेक्शन हुआ ही नहीं। क्योंकि जो स्पाइनल कॉर्ड इंजरी के बाद मैंने जितने लोगों को पूछता हूँ, आपको बताता हूँ कि पूरे इंडिया भर में लगभग 20,000 स्पाइनल कॉर्ड इंजरी लोगों को मैं गाइड करता हूँ फोन पे रोज। ओके, और हमारी उड़ीसा में 2,500 से ज़्यादा स्पाइनल कॉर्ड इंजरी लोगों के साथ फोन पे कनेक्ट रहता हूँ। अगर उनका कोई डिफिकल्ट क्वेश्चन होता है तो मैं चित्रा सर से पूछता हूँ, सर ऐसे पेशेंट पूछता है तो जो नॉर्मल क्वेश्चन हो तो मैं खुद गाइड कर लेता हूँ बिना मेडिसिन के। कोई मेडिसिन का, क्योंकि मेडिसिन का ज्ञान ही नहीं, मैं तो खुद नहीं खाता हूँ। फिजियोथेरेपी और हमारी रिहैब सेंटर ये बनाया। और मैं दावे के साथ कहता हूँ, और सर ने पूछे फैमिली पहले साल शुरू से लेकर
at SV Nirtar from 1981 to 1985. Then he worked as a superintendent physiotherapy at NIOH from 1985 to 1987. He was a lecturer at NIOH from 1987 to 1989. He served as an assistant professor since July 1989. I now would like to request Dr. Patita Pawan Mahanti sir to felicitate Dr. Srinivas S. Rao.
Thank you so much. Thank you so much, sir.
He also acted as a resource person for many special lectures and workshops across the country. He got awarded with C.P. Nair Oration Award by the Indian Association of Physiotherapists in 2007. He was also awarded with a Lifetime Achievement Award by Honorable Minister of State of Human Resource Development, Shri Satyapal Singh, at the International Conference of Physiotherapists held at AIIMS, New Delhi on 9th December 2017. He now serves a professor and the HOD of Physiotherapy Department at Institute of Health Sciences, Bhubaneswar. So, please give a huge round of applause for both of a legend of our profession.
Thank you.
Sir, I would like to request you for a few words.
Good afternoon to the delegates on the dais, colleagues, friends. At the outset, I take this opportunity to thank the ODISHA Service Association of Physiotherapists who have bestowed this honor on me today. Coincidentally, it is so that this is the month of February, it's only the last week of February, but I had joined Nirtar on the 1st of February 1977 as a physiotherapist. In those days it was known as CIPOT or CIPOT, Central Institute of Prosthetic Orthopedic Training. Later it became National Institute of Prosthetic Orthopedic Training, and sometime in 82 or 85 it became the National Institute for Rehabilitation Training, the so-called Nirtar, which presently its name is. I had served for 8 years, from 77 to 85 at Nirtar, Gorakhpur. Then I relocated myself to National Institute for Orthopedic Handicapped, which is today the National Institute for Locomotor Disabled, and retired from there. It's a great pleasure to meet so many young people here. My journey has been pretty long, and one of the best professions that one can opt for is probably physiotherapy. I can tell you this very boldly after putting on so many years of service. Teaching is a passion, so I'm still working. Though I'm 70 plus, I've not thought of hanging my boots as yet. If my health permits me, I shall continue that. So it's a nice gesture on your part. Once again, I take this opportunity to thank you all. Thank you very much.
Thank you so much, sir. I should request you people to please give some more round of applause.
Please put your hands together for Dr. Chittal Ranjan Mishra sir.
Now I'd like to request Dr. Patita Pavan Mahanti, Director SBL, to felicitate Sanatan Satpathy, Dr. Sanatan Satpathy sir, and Dr. Sir Kamalakant Naik sir, Mr. Kamalakant Naik.
Dear audience, I
Guinness World Record holder for Greater Pakistan, and all their achievements have been shown by
If you look at these slides, you can see hardly there is any medial condyle there to give adequate stability to this knee. So you can see this is how this knee is moving, and I think most of us who are present here may agree that we cannot preserve this knee, and obviously we did a TKR, and the next day he was put on weight bearing, full weight bearing by our physiotherapist, and you can see the person who was unable to stand or unable to walk, he was mobile next day. So this is the beauty of knee replacement. So high tibial osteotomy, and what we did actually in high tibial osteotomy is just
or eroding or stretching of tissue that has either been improperly healed or has become adaptively shortened. In dysfunction syndrome, the pain results when the structurally compromised tissue.
Good afternoon, ma'am, and all present here. My topic is spinocerebellar ataxia type case report. Spinocerebellar ataxia are ataxic disorders that are inherited in an autosomal dominant manner, despite the term spinocerebellar implying injury to the cerebellum as well as onset in his fourth decade. He had an MRI of the brain done that reported no abnormalities during the onset of his.
For the animals we stand. Let's go back to when trees were swung. Kids across the lane. Savannah, I'm coming home. Savannah, we'll never be alone. Savannah. Sebastian.